Members were provided a Zoom link to access the meeting remotely. As a reminder, remote access is allowed to all meetings for the 2022 regular session. So again, good morning. The meeting materials were put online earlier this week and made available for downloading. At this time, we'll have the secretary call the roll.
Representative Bowling,
Here in the room.
Representative Fleming,
Here in the room.
Representative Frazier Gordon, Representative Gibbons Prunty,
Here in the room.
Representative Sheldon,
Here in the room.
Representative Weber, Representative Westrom, Representative Wilner,
Here in the room.
Representative Petrie, Representative Reed, Representative Moser, Chair Bentley.
Here in the room. Okay. Members, you will need to indicate whether you're present in the room or remote, as said before. Okay. Now, I have a prior commitment, so I'm leaving now and giving the gavel to Ken Fleming. I'll be back in just a minute. I have two committees going on at the same time, so put that on the record. So Ken, here's the gavel.
Thank you, Chairman Bentley. I appreciate the opportunity to help you out in this process and so forth. Well, what we'd like to do today, this morning we're going to hear from the Behavioral Health Development and Intellectual Disabilities. And also we have Judge Stephanie Burke, who also provides some information on her experience during the first phase of the Thames Law. The presentation, you should have received access to that, I think last night or whenever it was posted. So they're going to go over that presentation to talk about the Thames Law. If you don't mind, just hold off your questions till after they're complete, and then we'll go from there. So with that, ladies, if you don't mind, go ahead and identify yourself, and then you've got the floor.
Good morning. My name's Tanya Dickinson. I'm with the AOT pilot project, assisted outpatient treatment pilot project with the Department for Behavioral Health. And with me is Deputy Commissioner Stephanie Craycraft. And we're very pleased to be with you this morning and to hopefully provide you some additional information about the project, and answer some questions if we can. Let's see, I think I have the ability to share my screen and go to the PowerPoint, and we'll see how that works out.
We didn't have her signed up or anything. Yes, she can speak, but usually we have to be given notice.
There we go. And I don't think we'll lose anything or lose too much with the little faces over there at the side, but if I have to, I'll move that later or even minimize it even further if necessary. The Substance Abuse Mental Health Agency with Federal Health and Human Services awarded the Department for Behavioral Health an AOT pilot project grant in July 2020. It's to address the assisted outpatient treatment statute that was originally known as Thames Law in Kentucky. It's a $4 million award, $1 million per year for 4 years. Services initiated in December 2020. We're projected to serve 192 clients across 2 state hospital regions. Phase 1, which is currently in operation, is with Central State Hospital Region with CommuniCare and 7 counties community mental health centers. Phase 2 will begin this August in the Western Kentucky Hospital Region, and that will involve Pennyroyal Center and River Valley Behavioral Health Community Mental Health Center regions. The map there is of the current pilot project and its operations. Phase 1 is in purple, Central State, 7 counties, and CommuniCare. Phase 2 is in green, which is Western State Hospital, Pennyroyal, and River Valley. And we have requested that the federal agency allow us to expand to 2 more of the community mental health centers serving the Western State Hospital region, so that the entirety of that state hospital region is covered. Fairly small counties, don't expect too many additional referrals from there, but wanted to make sure they were all indeed covered. The grant objectives are to improve outcomes for individuals with serious mental illness who qualify in specified regions, demonstrate cost savings, and develop a sustainable model for statewide implementation through collaboration, evaluation, and experience. And the use of the word improve outcomes is very specific. We recognize that some of these individuals are the sickest of the sick. We're not going to stop rehospitalizations or other consequences to them, but we want to reduce them significantly through the use of AOT. Costs that are covered by the grant: community mental health center staff and limited client support funds, training in assisted outpatient treatment services, materials development and publishing, and evaluation. Treatment, it should also be noted that while we do cover some treatment costs, providers do bill third-party payers whenever those are available for qualifying services. The services, the pilot project AOT treatment services actually delivered. We have a really extensive flow chart available on our website. This just reduces it to its simplest elements. The state psychiatric hospital initiates the AOT petition with the district court judge. The judge determines probable cause and orders the evaluation and treatment plan. After the completed evaluation, the judge may order AOT for up to 360 days with regular reviews during the term of the order. They could order it for a lesser period if they chose, or they could ultimately they could deny the petition. One of our earliest referrals was in fact denied. So we had 20 referrals last year, but only served 19 folks. Then the CMHC, after the order, provides services specified in the treatment plan, including therapy, medication, support services, and support services are just that. They are wide and varied per each individual. They could be everything from assisting with housing, which is probably the highest need with limited funds or no funds sometimes that we have for these folks, to on down to, we had a gentleman who was very difficult to understand and could not communicate his needs because he had no dentures. So we ended up purchasing a set of dentures for the gentleman, and that has helped him with his community adjustment immensely. During that 360-day period, the community mental health center staff deliver treatment, therapy, medications. They involve peer support folks with lived experience to help the individuals come learn a better way to live in the community. They also collaborate with the other actors and stakeholders that are coming into contact with the individual: law enforcement, frequently, family, and others, job development as they progress, perhaps, other community health or physical health providers to promote the individual's community success. The supervision is tailored very specifically to these individuals, with the tone of the judicial supervision and the frequency adjusted to where that individual is in their treatment plan. Early on, straight out of the hospital, they may meet with the judge once a week, once every 2 weeks. That might be extended to once a month towards the end if things are going well. And the judge has a great role with these hearings that they have, or meetings, intermittent supervision, whatever you'd like to call them, and they want to work with what the individual brings to the table. If the individual needs, a judge to be stern and remind them of their responsibilities that is under that court order, they can do that. Or it can be a much more friendly touch base with, how are you doing now that you've settled in a little bit. it varies by, all of it varies by what the individual needs at the given time. The evaluation measures that are included in the grant and are being assessed by our evaluation provider at the University of Kentucky on an ongoing basis are both individual and programmatic, as well as cost benefits. The evaluation measures for individuals and how successful are they in the AOT process and in the community are seeking to look at impact rather than participation. Particularly, we're looking at psychiatric hospitalization days, jail days, homeless days, substance use, emergency department utilization, Medicaid utilization, reported satisfaction with this process, and progress assessments are done every 6 months that an individual is within the program. Some of those are required by the federal grant that we have, and some of them are things that we found to be of particular use within Kentucky. The University of Kentucky evaluators will be accessing data from a number of sources that we've already contacted and told them that will be coming, and everybody is very interested in participating. Department for Medicaid Services, administrative office, the courts, our hospitals, which are participating, of course. We haven't had anybody tell us no, that they weren't interested. Everybody has seemed to believe this is going to be a very useful tool in our toolbox for folks. Programmatically, we'll again be looking at psychiatric hospitalization days, jail days, homeless days, emergency department utilization, Medicaid utilization, but probably more from the organizational perspective, how those are expensed, how those days happen when they're in the psychiatric hospital to prepare them for a better referral when they get closer to being ready to be released, that sort of thing. Also a cost benefit analysis so that we can truly look at it and determine that these are the costs of implementation, the costs of individual service delivery, and where does that save us money? How much is that benefit to us? It's kind of an old saw that you don't save a lot of money until you're able to close a unit or close a program, but you can improve people's lives and reserve those scarce hospital beds for individuals who need them more if we're keeping more folks out longer with an AOT supervision program. So far, the initial results from the evaluators have been promising, but there are no conclusions yet available. The first year they completed the data analysis we served folks for only 9 months out of that year. And that's the grant year. And I should mention that the grant year and the state fiscal year do not match. They're very close. But we're always trying to talk about year one grant statistics as opposed to any exact fiscal year or calendar year. At the end of that 9-month period, only 4 folks out of the original were even eligible for the reassessment at the 6-month mark. So the evaluators did not even report that information because it was of no statistical value at that point in time. Like I say, promising, but not as informative as it needed to be or clear as it needed to be. The year 2 report, which will be due out about the end of this calendar year, will have much more utility for making those programmatic evaluation measures, and we'll certainly be publishing it to our website and sharing it far and wide. The data that was collected for the end of the grant year 1 is here. We're now up to 30. We just had one come in yesterday. I think we're up to 32 or 33, and that puts us on track for this grant year to meet our goal that we established in the grant. The responses, the information is likely a lot of what you would assume. The most common diagnoses is schizophrenia. Demographics, more male than female. A little less disparity, but primarily the individuals who've been referred have been white. As opposed to other racial groups. I don't think we even had anybody in alternatives beyond those two categories. And I don't think we had anything tracking we asked the question, but we didn't have a substantial number report Hispanic either. Main age groups are kind of those folks who are going to be most affected by schizophrenia, fairly young. 26 to 34 is almost half of the folks that we've had. 35 to 44 makes up much of the rest of them. Education, folks reported attending or completing, a few folks reported attending or completing college. About a third completed high school or GED. And then about a quarter reported less than a 12th grade education. Employment, most of them reported being unemployed or disabled, not working one way or the other. And all of these, the majority of these, if not all of them, they were asking the individual about the past 30 days while they were coming to the very end of their hospitalization. So we expect that the 6-month follow-ups will have some fairly different results. Aside from the age and sex, I think any of them could possibly change. Diagnoses may change over time. Things may be remembered or reported differently or researched by the community mental health center staff to get a different answer. So we expect there to be variation between the initial and the 6-month reports. Overall health, about half reported being in good health, about half reported being not such good health or having challenges. Many, if not most individuals reported quality of life issues. Also, as you might imagine, folks have some coping abilities, but there's a lot of challenges there. Medication adherence, reporting always taking their medications in the past 30 days. That was one of our anomalies. If they're currently in the psychiatric hospital, we expect that most of them are, but we worry that that might have been the wording of the question. But again, we're not in control of those. That's a federal survey that they use. That goes along with alcohol use. The vast majority reported no use within the past 30 days. That may be because they've been in the psychiatric hospital or because of some other bias when they're reporting. Cannabis use, cocaine use, methamphetamine use, those are all part of the items reviewed by the federal survey for incoming individuals. About a third of the folks that came into the program reported having support or having someone who will support their recovery in their lives. That's not a great number. Folks have burned bridges with their families, and part of the community mental health center getting them to be successful in the community as time goes on and they become more stabilized is to help them reestablish those relationships. We're not the experience or witnessing violence question. If that's of the last 30 days, we're not sure. We're not sure what that means. That's one that we're following. Not so much violence going on in the psychiatric hospitals, but individuals may have been reporting, restraints, or it may be prior to entry. Again, we're not sure, and that's something for us to follow up on. Medical and correction interventions, another item that we're following and that we're going to follow long term as well for the 6-month follow-up that we do with folks. Sorry for the density on that slide. It looks much prettier in the UK report that they published, but trying to keep the number of slides down and keep it all readable for you. The grant year 1 report notes are from University of Kentucky are included here because they refer back to the report, but it's all things that we covered in conversation, I think. but in case anybody printed this off and went to take it with them, we wanted to make sure they had that to refer back to. AOT costs. That's always the big question. What does it cost to deliver this service and have these programs in operation and accessible to folks? Each of the CMHCs serves a somewhere between 7 to 17 county area, encompassing multiple judicial districts. And the CMHC expenses under the pilot project include staff costs, including an AOT coordinator who serves the entire CMHC region. They don't focus on the single judicial district necessarily. That's probably less important at the time that the petition is entered, because there's usually one court serving as the location for the petitions as they come out of the state hospital. And then those folks are sent back to their home communities or wherever it is they wish to reside. So there's a transfer of supervision between the court that orders it if they live outside of that court's jurisdiction. We've had actually a couple of folks who have transferred back and forth between the 7 counties catchment area and the CommuniCare area for the CMHC supervision. But all of the petitions for the Central State Hospital region have been gone through the Jefferson County District Court. In addition to that coordinator, there's the full variety of professionals that are needed to serve individuals with serious mental illness: targeted case managers, peer support specialists, other clinicians and clinical support, psychiatric, psychological time, things like that on a consulting basis. Operating costs for reporting and oversight, office space and supplies, administrative support, human resources and fiscal, training and certification to keep those individuals' licenses and certificates up to date so they continue to provide those services. In addition to the AOT staff, the Community Mental Health Center will refer individuals to other services, both within their own organization, if there's a specialty group within them, or they might refer them out to some external source, some external provider, depending on what it is. Many of the individuals that are on AOT receive some services from the Assertive Community Treatment, or ACT team, that each of the community mental health centers have. Not everybody. Some folks have tried that before and it was not successful. And so those individuals generally aren't referred back to ACT. But again, it's so highly individualized, it's difficult, particularly with the small number of folks that we've seen so far, to give you a typical client or a typical set of services that they receive. In addition to the staffing costs and the structural costs, there's client support funds that are included. We don't have as much flexibility as we would like to have with those because of the federal guidelines for grants fund spending, but they do go to support housing, transportation, certain medications and medical services, personal items. I will tell you that stable housing has been the biggest challenge that we've had with folks coming out of the state hospitals. Many of them come out homeless. Back to that one statistic of only a third having a good support system. They're usually not going home to live again at mom and dad's. They've run out of those general options, and housing costs can be anything from rent to utilities, they're generally, though, in existing structures. Finding the individual a supported housing apartment somewhere, a HUD 202A complex, for instance. CommuniCare has a small house where they have folks that are able to reside. So really, again, just as diverse as the population, what their needs are. The individual who needed dentures, he really needed that so that he could communicate with folks and be a little less scared and a little less scary, frankly. Behavioral health departments costs includes oversight, through a project director for fidelity and accountability amongst the various locations, community mental health centers, psychiatric hospital staff referrals and coordination, evaluation by the University of Kentucky. It's federally required for the grant, but we intend to continue with that as part of the effort to maintain fidelity and accountability and to track how the program progresses as it goes on in time, and provision of training and support. We're planning to send a number of folks to the national conference later this year so that they can get some exposure to how this is done in other jurisdictions. Everybody has such different statutes that no two are ever going to match. But we, don't want to reinvent the wheel if you don't have to. We're looking for the innovative things going on in other jurisdictions and how we can best access those and adapt them for Kentucky. The fiscal biennium requests that we have budgeted for and are hoping to have coming up in state fiscal year 22-23. We're hoping to have $500,000 to initiate these services in the Eastern State Hospital catchment area and its community mental health centers to serve them. In the second state fiscal year, we're hoping to have $1 million added to the budget so that we can expand that to Appalachian Regional Hospital and its community mental health centers in their catchment area. There is one note for us. The federal grant funds expire in July of 2024, and in order to maintain what we currently have, we'll need to request additional funds at that time to cover those, to continue coverage in those hospital areas. These funds will expand the pilot project. Kind of the point of a pilot project is to continue its operation for a given period of time. In this case, for the grant is 4 years, so that you can track how the program develops, how expenditures develop and are modified throughout the period, so that you can track the individuals participating on a longitudinal basis, but trying to keep the same set of rules, governing rules for all the participating agencies, so that we have some comparable data when we get to that point. And then as a follow-up, that is the statewide AOT project service area. It's very colorful, but all it really is showing where the 4 state hospitals are and the community mental health centers within their catchment areas. And that's about all I have, unless Deputy Commissioner Craycraft would like to add something.
I think you've covered it all, Tanya. Thank you.
Great. And that is all we have. Are there any questions we can answer?
Well, thank you very much, Ms. Dickerson. I appreciate your presentation. Give us an overview of the program in itself. What I like to do is just hold off on asking you questions. I'm sure some committee members will have some questions for you. What I like to do is, okay, thank you. I would like to have somebody who's on the ground floor. You mentioned Jefferson County is mainly a lot of the volumes going through that. I'd like to ask Judge Stephanie Burke to come up and just sort of give a ground work perspective on what she's seeing and what she's experienced and so forth. And, hopefully we can try to keep this about 10 minutes or so. Judge, that'd be great. If you don't mind, just identify yourself for the record and we go from there. And then we'll come back to you. Thank you very much, though, Ms. Dixon.
Shall I stop sharing the screen?
Yeah, you can stop sharing the screen. That'd be fine.
Right.
Actually, well, you can always come back to it. That's okay.
We can always go back.
That's right. Thank you.
Good morning. I'm Judge Stephanie Burke.
There you go.
I am the judge who presides over the AOT court in Jefferson County, who serves the individuals coming out of the state hospital at Central State. This is the initial site which was provided funding through the SAMHSA grant, which was granted in 2020. Currently, we have, as Tanya said, we have had approximately 31 total referrals to the AOT program. Of those, 12 have gone back to Communicare in Hardin County. 2 of those, once referred to Hardin County, did come back to Jefferson County. So like she said, some of the individuals kind of transfer back and forth between the counties based upon their current residence. Sometimes that happens because the individual goes back to the hospital, and when they go back to the hospital in Jefferson County, the case comes with them. So the case follows the patient. So we currently, in Jefferson County, have had, I believe, 21 individuals. Sadly, 2 of our participants are deceased due to their substance use disorder. Both of those individuals resided with family prior to their petitions for AOT. Currently, we have 17 active participants, 1 participant who has actually completed the program, and we have 2 persons currently incarcerated. So we're not able to serve them while they're incarcerated, although I will say that my team does work with Louisville Metro Corrections to make sure that the individuals' medications, they are getting the correct medication while they're incarcerated. They stay in contact with those individuals and are monitoring their cases. We have a public defender assigned to our team, and so they're monitoring those individuals' cases so that when it's time for them to be released, we've had 1 person go into custody and come out of custody, so we made sure that they had appropriate placement when they came out of jail and that they got right back into treatment with 7 counties. So we're following these individuals very closely. I have an AOT coordinator. His name is Aaron Bates. He has a lot of experience as a court coordinator. He was the 7 counties court liaison prior to taking this position through the grant. He monitors all of the individuals who are coming into the program, and he is the person who comes to the court and does all the reporting to the court on the client's progress. He can provide me any information at any time about the client, their whereabouts, what's going on with the funding for the person's housing, who's the person supervising the client, how many contacts the client has had with the team, whether the client has taken their medication in that period of time. They'll tell me the dates that they have had contacts with the client, who all had contact with the client, whether the client may have came in on a Monday for their appointment to get their injection, or a lot of times what we see is we don't have the client come in for services, our team goes to the client. So our team will go out, and sometimes the person will say they don't want the injection that day, but they'll agree for them to come back tomorrow. And so the team will come back tomorrow. And so when you heard Ms. Dickinson talk about tailoring this to the needs of the patient, that's exactly what the team does. We have a targeted case manager named Adrienne Scrucy. She's incredible. What she's doing is amazing. She comes to the docket as well and reports all of her contacts and communication with the individual patients. And she is in communication with all of them all of the time. She will a lot of times spend time outside of their homes because they will, so many of them are suffering from schizophrenia, so they have severe paranoia. So a lot of them will come outside and sit with her on their porch, and she'll just stop by to say hello. So she's building relationships with them to build that trust, and as that trust is built, they become more cooperative. And we are seeing great success because of these relationships that the team is building with the patients. And some of the patients initially were afraid of coming to court, and we don't want to pressure that. So what we would do sometimes is we would start by calling the patients or getting them on FaceTime. And then as they become more comfortable with the team, they would transport the patient to court. They would drive them to court. Some of them are too afraid to get in the car. So it's just, what does the patient's need? We have some patients that are happy to come to court. They have family members who will bring them. Some of them have had different family member bring them every time so that we can meet all the different members of their family. So we have one gentleman who his mother has brought him. His brother brought him over the holidays because he was visiting. Another family member brought him on another time, so we've met all these members of this young man's family. With respect to the patients in Jefferson County, most of them, of the 17, most of them are living with family or a relative placement. So they're living, a couple of them are living in their own housing that they have through their income. Most of our patients have SSI income. If they don't have it, our team is working to help them with their applications. Many of them have been in and out of the criminal justice system, so when they go to jail, they often lose their SSI, so we have to go back through reapplying and helping them with that. Many of them do not have the capacity to maneuver that application process on their own, so my team is excellent at assisting the patients in making sure that all the applications and so forth are completed so they get all their benefits put back in place. And so most of our patients are getting SSI benefits. We have a couple who are not. We have a young man whose family is from Africa. The family is currently in Africa. They took him back for the holidays for a visit, and he's not eligible for SSI benefits. So he does live with the family. They have the means to provide for his needs. We have one individual who recently came out of the hospital, and we did not have housing resources for her. She's getting housing at a higher level of care because she needed assistance with someone providing, being able to administer medication to her because she's so young, and we were able to place her in a family care home that is licensed so that the individual is licensed and certified to be able to administer medication to her. That placement is an expensive placement. That is being paid through the Olmstead housing grant, which we can use for several of our patients if we need to. So we're able to use a lot, as Tanya said, we're able to utilize other sources of funding, but our team works to make sure that we get the housing sources some way. We have had a couple of patients come out of the hospital where we needed emergency housing, so we've ended up putting them in a hotel briefly until we could arrange housing. But as she said, housing is the number one barrier often to meaningful success in long-term stability. So we have to deal with that first. That's dealt with before coming out of the hospital. We want to make sure we have a placement before they come out. And that's normal for individuals who are in the state hospital. Even if they're not in the AOT program, the hospital has contracts with providers in the community to make sure that individuals coming out of the hospital have a stable placement to go to. They don't typically just release people to the street. That's would be highly unusual. They normally have some place for them to go, even if it's a shelter or somewhere safe, but they don't like to release people not knowing where they're going. So with AOT, we try to do a warm handoff to a safe place where they can start the services right away. Our team gets involved immediately through our targeted case manager. And currently, we do not have anyone hired specifically for the peer support position. We're hoping as we grow that we will have that. And as far as additional services and transportation, some of our team does do transportation for the individuals in the program. They'll drive them places and to appointments and things like that. Most of, as you, I believe we've explained this in the past, that we're not providing additional services through the grant. Their treatment is not something the grant pays for. The treatment is something that they get even if they're not in this program through their Medicaid. So it's through other payers. We don't want to, in AOT, provide them with some false source of treatment and services that once we're out of the picture that would not be sustainable for the patient. So we have to be careful not to get, we wouldn't want to give them a whole bunch of extra resources so that they would be successful, and then when their AOT order ends and the program goes away, that they would be set up for failure. So we're trying to create a structure where they can be successful with the resources that they have available to them without the program. And what we're doing is it's the increased case management and the individuals giving them their the fact that the services come to them makes a big difference. But the longer the patient is compliant and medication compliant, adherent to outpatient treatment, you see that their baseline will stay better longer. As you see them move along in the program, they become more amenable to the treatment. They like seeing the change in their life. I had a young man in court this past week. He's going on about 8 months of being compliant and being well, about as well as he's probably ever been. And he's really happy. He's really, this is life-changing for him. And he's happy to keep doing this, and he's talking about voluntarily extending his order. And so he likes the team. It's the relationship. He likes, Adrian coming and checking on him. He likes talking to his therapist. We have a therapist on our team who also comes to the court sessions, who will tell me, what's going on, with each of the patients and how they're progressing or what they're struggling with. And this team has created it's just a safety net, but it's so important, those relationships, because as anything that you learn about AOT, the special sauce is that relationship that gives the person the impetus to be successful. If you bring the patient into the program while they're stable from the hospital, so you catch them as they come out, they don't want to be in trouble. They don't want to have contacts with law enforcement. They don't want to go back to the hospital. You keep bringing them into court, bringing them to see the judge. You build that relationship with the judge, which is called the black robe effect, and you keep having these frequent contacts with them, and you see this kind of light bulb go on. And the longer we can sustain that, I can tell you, I've told you before about the initial patient that we had in the program prior to getting the grant. That gentleman had had 50 hospitalizations in under 10 years. When he wasn't in the hospital, he was in jail. He has a state guardian who was kind of instrumental in him getting an AOT order, made sure he got to court every time. We supervised him for a year. He didn't have any hospitalizations or incarcerations in that year. This month is the 3-year mark for that gentleman. All those services that he was getting during that year, he's still getting through 7 counties. He's not been rehospitalized, and he's not gone to jail in 3 years. That year of stability set him up for success. I saw his mother in the grocery store at Christmas with the state guardian, and the conversation with this woman just made every bit of this completely worth it. Just that one individual alone, saving the dollars, if you want to talk just about the fiscal part of this, the dollars that's been saved with that one individual, if he had continued on the path that he was on, would have been millions of dollars being spent on contacts, hospitalization days, contacts with law enforcement, which were constant, CIT runs, crisis intervention, emergency room dollars, and we know that this population, when they go to the emergency room, they're there a lot longer than if you and I were there. Okay, because they don't know what to do with them sometimes when they get there, and they're just there a lot longer, and that's very costly. But the burden that they place on society by their behaviors, you cannot put a dollar figure on that. It's extraordinary for their neighbors or their families, the things that they do that, cause difficulty for others around them, and the challenge they place for the people who are responsible for caring for them. He has now became the caregiver for his mother, who's battling cancer. You cannot put a dollar figure on that, and we now have 17 individuals. Hardin County has 9 individuals. we need to expand this statewide. The savings will be extraordinary. The more we can do of this, I was speaking with the folks in Hardin County last night. They're very excited about this bill in the new language and expanding the criteria so that we don't miss any of the folks who need this. We want to make this criteria more broad so that we can get more people and that need it and that really fit the criteria of who this population is. And we're all very excited to do this, so thank you.
Thank you, Judge Burke, for your I guess personal experience and giving us a backdrop on what's going on the ground level. It gives us a really good perspective of what's going on, and I appreciate and I appreciate both presenters in terms of giving us an understanding of what's going on. Obviously, this is a budget review, part of the appropriations of revenue, and so we're going to be focusing on. I like to focus on costs, like I am, in terms of trying to figure out the use of the money and how it's being spent. And I know Ms. Dickerson mentioned about the cost analysis and so forth. And you also said you have around 19 people you're serving, but I think the judge mentioned around 30, and so. I want to, I guess, before I ask other members to jump in, which I know we have several people who want to ask, I want to get an understanding. So it's $1 million a year for 4 years. Can you give me a perspective on the total cost that you've incurred at this time and what those costs make up?
Do you want to, or do you want me to? Go ahead. I'll let Deputy Commissioner Craycraft do that since she. Of what? People or dollars? Dollars. I didn't bring the latest number with me. I brought the year one that we calculated based on. Almost 400.
Right. Okay. I'm sorry, we're getting an echo. Okay. Yes, we spent close to $400,000 of that million the first year. I think as Tanya mentioned, I think we didn't start serving folks until December of that year, so it was a partial year. The majority of those costs are expenses. They're payments to the community mental health centers. And as Tanya listed in those slides, that those can cover a number of the community mental health center costs, staff time, some of their operating costs, some costs for individuals that are not covered by insurance or other third-party payors. And so that's really what most of the funds was used for. We did have a project director, and so the project director costs came from that. And then we'll also cover the cost of the evaluation for the University of Kentucky.
Now, the first year was $1 million. So what happened to the rest of the money?
Oh, let's see. I'm sorry, I couldn't hear your question.
You mentioned that $400,000 thereabouts that has been spent so far, but the first year was $1 million, and each year is $1 million. So what happened to the rest of the $600,000?
So the funds are federal funds. They will carry forward. And I think Ms. Dickinson mentioned in her slide that we have requested through SAMHSA to be able to use those funds to expand to the other two community mental health center regions in Western Kentucky. We're still waiting for approval for that. But when that's approved, that's how we'll expand to cover the rest of the western part of the state.
So you're going to get another $1 million next year for the western part. So now you have $1.4 million. How's that going to be spent? Because you mentioned about around 200, roughly around 294, I think, folks that will serve over the 4-year period. If you annualize that out, it's 50 per year. You're at, my understanding, around 30 right now, thereabouts. You're still short 20. Could you give me an explanation on how that money's being spent? Because I'm a little confused.
You want me to
Go ahead.
Let's see if we can do this without echo. There we go. The carry forward money is is essentially a one-time carry forward, and then we will be asked to, if we take on, if the federal grant allows us to take on 2 additional community mental health centers, with carry forward money from one year to the next, we will have to use, they won't let us do that if we can't incorporate into that $1 million annual budget going forward that we can continue to serve those counties.
I appreciate, but I'm struggling with what you're telling me. I mean, I understand what you're saying, but if you're short already the number of people that you're projected to serve, and you're going to have another allocation money that you're going to try to expand it further, to me there seems to be this service is not getting out there as quickly as possible. And so to me there's a gap. So that's why I'm trying to get an explanation of that.
Actually, I don't think we're going to be short this year. All of the federal grantees in our cohort, they've been awarding these funds for a number of years. And the ones in our cohort, almost every one that I was aware of was short on their projected numbers for the period that they received that grant, due to a variety of factors, I'm sure, in each of the locations. But since we did not start taking clients on until December, that was probably the biggest reduction in the number of folks, and that was the first year. I don't think, certainly our grant project officer isn't making decisions about our ability to serve our annual numbers based on that first year that began in 2020 and finished up in 2021. That was not of concern to them. As far as our numbers for this year, we should have a total of 35 clients. And I think we've had 11 or 12 that have been referred during this grant year 2. That puts us on track to get our 35. We expect a dip around the holiday season. So we expect that the numbers will start picking up again here shortly. Now that the holidays are past. So we expect to make our numbers of 35 this calendar year, or I'm sorry, this grant year.
Okay. But okay, I'll tell you what. Let me. I know there's some members. I'm going to give them the opportunity, and I have some more additional questions because I'm not getting what I guess I'm a clearer explanation. I think Representative Bowling had the first question. Go ahead, Representative.
Thank you, Representative. Almost called you Bentley Fleming. Thank you.
I'll be a compliment. Yeah.
You actually asked a lot of the questions that I had. But a question on the last comment Ms. Dickinson made was, you mentioned 35, like that's your goal is 35 patients. And I see like in the original grant application, it's projected to serve 192 patients over 4 years, which is 48 patients a year. So there's been a change of the amount of patients that you're able to serve. Why has that change occurred?
I think that was the original grant application assumed that there would be fewer people the first year. I think the first year's target was 27 and we ended up with 20.
Okay.
So
second year, I'm sorry.
No, go ahead.
So second year would be 35, and does it just ramp up from there?
It does, because in phase 2 of the grant,
Right.
Which will begin in grant year 3, we will add on the Western Kentucky counties.
Okay.
And also we expect to add additional cases in the central state region. As more people become accustomed to it, it becomes more ingrained in hospital operations to identify folks for petition, that sort of thing.
Okay. And your all's hope, if you get the approval of SAMHSA, did I say it correct?
Close enough, everybody. It's SAMHSA.
SAMHSA, okay.
The H is silent.
Okay. But that you all, if you're approved to use that $600 million moving forward, that you would effectively, I know you've used some this fiscal year, but when you're talking about fiscal year 1, just having $400,000, you'd have $3.6 million moving forward to complete this grant?
Correct,
Okay.
I think.
Two more questions, if I may. What positions have been fully funded out of this grant, and are there any positions that have been partially funded? Do you all have a list of that?
I'd have to get a complete list of that, but I will tell you that each of the community mental health centers operates just a little differently.
Mm-hmm.
And then also they have a number of folks who they're paying 0.5 full-time equivalent. So we have, it's a full-time person, but they're only dedicating half their time to the AOT grant. That makes sense as you're starting up a program. And it also makes sense when you're using the kind of scarce psychological resources. You're not going to pay for a full-time person. You only need 10% of that individual's time to serve this given number of clients. The one basic requirement of the grant was that each community mental health center have an AOT coordinator. So that is that person who is in contact with the courts and oversees the general delivery of services. And Judge Burke is correct. Aaron Bates in 7 counties is a wonderful person and a treasurer, and he keeps all the plates spinning on the sticks. But he would also be responsible. I think we also have one Oldham County case, or the individual came and went from Oldham County. So if we do any business in Oldham County, Aaron would also be the representative who would attend the Oldham County courts. In Communicare, we've had most of the cases out of Hardin, which is obviously the largest metro area, but also had one out of Owsley County. And so that's also how we do outreach to judges, is that, letting them know about this service. And it's easiest to get them more information, more detailed information once they have a case before them. So that's
okay.
So they're, like I say, it's a variety.
Right. It sounds like it, but if you could just help us somehow get down on paper what that looks like, because we're talking about a pilot project right now that the state,
Sure.
Will decide to fund moving forward. And if we know, your plans for expansion, I know you all have those plans. You have phase 2 and further phases, I'm sure, but we're just looking at from the state side of view, or from the state's point of view, how much funding do we need to allocate? How many people do they need?
Sure.
How much funding is directly tied to this AOT program? And another thing we didn't talk about is direct costs that have been paid on behalf of AOT participants. I don't know what that number is. I know you said that if it's a billable service, or you can get paid from someone else, you try to do that. But then I do realize that there may be some gaps there, and we'll need to know those as well.
A condition of the grant is that it is to be the payor of last resort.
Right.
So if there are any other funds for client needs, they're supposed to, the programs are supposed to seek those out and use those elsewhere.
Right. But if you ever end up the payor of last
Right.
need, what are those costs is, I guess,
Right.
what I'm asking. So.
Right.
So that information would be very helpful, and thank you, Rep. Fleming and Chairman Bentley.
Thank you, Representative Prunty.
Thank you, Mr. Chairman. I have several questions, but a lot of them are programmatic, so I'll leave them for another day. The financial questions are, you mentioned that you don't have flexibility with some of the since they're federal dollars, you don't have flexibility. Have you petitioned, or do you need some petition to the federal delegation to try to help with that issue, or?
No, I think it's mostly a function of the published grant rules. They want to be good stewards of their funds, just like we do. And for instance, we were discussing using incentives to incentivize folks to, attend their court hearings. For instance, you come to 5 court hearings, you'll get a gift card kind of thing. And while the project office allows some incentives, particularly for participating in SAMHSA's required surveys, they won't allow incentives for other things because of the potential consequences in sort of in the treatment environment. You know, if you pay people to come to their treatment appointments, then they're going to come, but they may not be as honest as they should, or they may manufacture reasons to come more often so that they get more incentives. So we're frustrated by them. We'd always like more flexibility, but those are the rules, and that's fine.
Thank you. One follow-up, Mr. Chairman?
Yes, ma'am. Go right ahead.
With your analysis and all the costs and so forth, could the savings eventually fund the program over time? Has there been any look at that?
I don't know that it could ever eventually fund the program completely. The programs are, you know, they're designed to start up and need some startup time and costs. So you pay more of your staff salaries up front and early on. And then as those folks come online and bring in clients and again begin getting an income stream coming back from their billable time to Medicaid or private insurance, there's going to be more subsidy to that, but you don't really save money at the department level anyway. You don't really save money until you could like close a unit at a state hospital. And I don't ever see this getting to that point. There will always be a need for a subsidy level of you know, some baseline staff for activities that are never going to be covered by third-party payors. The time that the AOT coordinator spends in court, that's not billable to an insurer. So we'll always have to pay for that time. The staff time that's necessary to you know, go out and pick the individual up and bring them back for court is probably not billable time, perhaps for a peer support specialist billable time, but that's the least paid, that's the lowest salaried person on that team. So that would not be much of an incentive for the agency.
Thank
Does
you
that
for
make
that.
sense?
Yeah, yes. Thank you for that answer. I just think that if there are huge savings across the board, that could be to the state's advantage as far as for other things they have to pay for. So I get that you wouldn't have decreased costs, but there might be savings for the state. And just thank you for the allowing this. And I'm excited about it coming to Western Kentucky. That's my district, and I know that it's much needed. And so I look forward to the progress of the expansion across the state. Thank you for your.
We had planned to come out and do some advance work in Western Kentucky and meet with local stakeholders, but we got delayed by, you know, the tornadoes, and so we had to reschedule everything. So that'll be a little bit later, but we will be sure to be talking to you when we're out there.
Thank you, Mr. Chairman.
Yes, ma'am. Representative Wilner.
Thank you, Mr. Chairman, and thank you, both of you, for your presentation. And I'm not even really sure who I'm directing this to, so whoever feels the appropriate person to answer this. I know that when Tim's Law and advocacy for that first started, it was to do exactly what Judge Burke has described and to get people out of this revolving door of hospitalization to incarceration to living on the streets, et cetera. And we know that there's tremendous cost savings in that, although it may not be directly to the department, as Representative Prenti also indicated. But I guess, how are we managing the referrals? How do people get off of the mental inquest tract and onto the AOT track to get out of that revolving door and into, you know, onto the path for a more sustainable recovery, even with their severe mental illness?
The pilot project defined how people would enter the program. And very, very specifically, they're folks who are within the state hospital and have been committed as part of the 202A process. And then as part of their release planning from the state hospital, then the hospital will file a petition with the court, and the community health center will do an evaluation. That sounds very clinical and clearly divided, but it's as much an art as a science. And I'm not a clinician, and I appreciate those folks who do that, because I'm not sure that I would give the best services that person needed. I'm much better at the administration side, but as part of the overall process, 7 counties services, for instance, it meets on a weekly basis on these and other patients at Central State Hospital to do their release planning. So it's a joint effort between the both of them to identify who would be an appropriate referral. And a lot goes into it. It's not just, the way the current statute is now is that the individual has been psychiatrically committed to a hospital twice before in the preceding 2 years. It's a lot more, there's a lot more art to it than just reading that statute. They tend to look at, has the individual gone through the graduated steps of treatment that is available to them. One of the frequent comments that I get from the treatment side folks is that if the individual has not participated previously in ACT or assertive community treatment, they want that individual, and there's not some other reason that they shouldn't, they want that individual to try that as having been a less restrictive method of providing fairly similar, fairly intense services to that individual. I think it's generalized. I think it's much easier when you're providing treatment services to provide them to somebody who's there voluntarily. Making a court order for someone to receive services is a significant step, even if it is outpatient. So they want to make sure that all of the foregoing steps have been touched or at least looked at. And if the individual is not found appropriate, then they might, but they would like them to have tried those less invasive possibilities first. Does that answer your question?
Partially, it partially does. I
have a comment about that. I think that is, unfortunately, that right there, that whole analysis of least restrictive is excluding many candidates who would benefit from the actual work of the team and would benefit from the court order. I think that it's just a matter of philosophy, but I do believe that in history of seeing specialty courts be very, successful, we know that in drug courts, in veterans treatment courts, and criminal mental health courts, how successful they are. If you use the same analysis, it's the court order that's the special sauce. And here, if we're not utilizing that for some other criteria that's not really what the criteria of the statute is, I think that we're losing people that would really benefit.
May I continue?
Yes, ma'am.
That really does address my question. And are we losing people who would really benefit? And I had the privilege, along with several of you guys, of serving on the Severe Mental Illness Task Force over the summer. And this was one of our top recommendations, was to expand court-ordered assisted outpatient treatment across the state, to Western Kentucky certainly, but across the state. And we know that it's been successful in 40 or more other states. And I guess I'm wondering if there are two separate things going on, if there are the constraints of the federal grant, and then there's what really Kentuckians need. And if we could be looking at expanding assisted outpatient treatment across the Commonwealth, sort of outside the constraints of this federal grant.
Mm-hmm.
And if I may, ma'am, that's I was only speaking to the project. That's the grant defined project. The larger statute, that does, and the proposed changes to it, that does open it up to a different group of folks, to a much broader group of folks.
That's very clarifying. So thank you for that. And if I just one more, and this is sort of an adjacent topic, but I mentioned the Severe Mental Illness Task Force, and one of the top recommendations also, in addition to expanding Tim's Law, was SMI waivers for supported housing, and I heard both of you mention housing as really being a problem and a barrier to folks being able to benefit fully from AOT and to benefit fully. So I guess quickly would love your thoughts, with the chair's indulgence, on the SMI housing waiver.
I think it's critical I think it would be a critical benefit to this folks that we're seeing, to get over that hurdle. If we could deal with the housing issue more easily and provide just that simple stability of not having to worry about that, not only would the cost savings be so much more, a lot of the population probably wouldn't end up in the situation that they're in if they had stable housing. Living on the street becomes a barrier to so many things, particularly maintaining outpatient adherence when they don't have a place to stay, a stable place to stay. You know, their caregivers can't find them. They, when they're roaming around, they can't get, when I'm talking about the team being able to go out and give them medication and coming to them, even when you have services that are that intense, if the person isn't in somewhere stable where you can find them, then it's all for naught.
It's very clarifying, and I think it really underscores the good work that the task force did, and gives us a direction for how I hope we'll be proceeding to address the needs that you guys have so clearly identified today. So thank you.
Thank you.
Thank you, Representative. Ms. Dickinson, I wanted to ask a question before I refer to somebody else who wants to ask a question. Could you provide what the cost is per client at this point? You sent some information to LRC staff, and I want to see if you can sort of define or let me know what the cost per client is right now.
That's just an aggregated cost. The amount that was expended divided by the number of people who had been served during grant year one.
And what is that cost?
I think it was about 18,000, if I recall right. I'm sorry, I don't have that sitting right in front of me.
Okay, I think it is around 18 to 19,000. So the next one you mentioned about housing, which is a topic a few minutes ago, and in your comment to the LRC staff, you said that's gonna result in significant costs and so forth. But the judge mentioned something about most of these individuals' housing is already taken care of, or they're finding accommodations with existing support, rather financial or from a fiscal point of view. So where are you coming up with the $6,000 you estimated in that?
The estimate was based on a basic calculation to have the ability to cover everyone, because not everyone has housing the moment that they leave the state hospital. Frequently, the housing has to be changed somewhere in the middle of the course, that they go to live with their brother, and that doesn't work out. And so they need to find the individual new housing immediately. It was truly an estimate, but one that was designed to cover the various costs and an average per person. Not that every person would need it, but that some will need more than others. Some will need that family care home type atmosphere. It was again an estimate so that we would be able to cover all of it.
All right. So based on the 6,000, let's just use your number for example, which that's probably less in my opinion, but that's something else. But so you got 6,000 plus, the 18,000. It's $24,000, $25,000. It's going to cost that in your application. To get this grant, you said, or the information says, $100,000 that individuals that incur costs to reduce the hospitalization and incarceration issues. So that's a significant savings. Could you comment on that in terms of what the cost benefit is? Because you mentioned that in your presentation. But to be honest with you, I haven't heard anything about that. I mean, I haven't heard, and I haven't got any hard data that I can look at. And sorry, it's my business perspective in terms of cost analysis. So you have $100,000 that the application says. Now you have $25,000 over here. Could you help me out with that?
I too like cost benefit analyses. I'd like to be able to point at data and say, this is what it means. There are, a couple of levels. You need to deliver the services directly, but then you also need to know how much it costs and is this the best use of our funds? And if there is savings, how much is it and where is it? Where can you go touch it? Kind of thing. I'm not sure that you'll always be able to say, well, we saved $75,000, and so now we're going to go spend it here. Because if you don't hospitalize someone or they aren't arrested, you've saved that individual from incurring a cost tied to that individual. But unless you can close a wing at the hospital, or you can close a cell block at a jail, you're still going to have to maintain those facilities. So it's the reason that University of Kentucky was included to do a cost benefit analysis as over the term of the grant was to determine those things, to determine both the individual costs and benefits, as well as if there's any systemic ones. So we can.
Has that been done? Have you put together that?
We're working on that. That was why.
But you've been in a year so far, and I know you started the program, but we're about a year, and when from my business perspective, when I do things, I have an ongoing analysis of where I stand and what's going on, and I think that should be applicable to government as well, because we're beholden to the taxpayers and making sure that, regardless of it's federal money or state money, we need to figure out where we are in any stage of the game when it comes to delivering the service. And I'm not hearing that that's been done. And if you're looking at $100,000 savings or savings in terms of hospitalization and such, and I'm not including all the other ancillary things that come into play, like the court appearances by the clinicians, by law enforcement, all that stuff comes into a pro forma and understanding what the cost is. But I'm not hearing that. And if we're looking at expanding this, we've got to figure out how much potential savings, because the application looks at around $180 million that we could be saved based on 1,800 people. And so to me, that should be there needs to be more of a control and understanding of what's going on, where we're going down the process.
Absolutely, I agree with you wholeheartedly, and that is the intent of the grant. But the grant is designed that we have 4 years to assess that, so that we have a large enough number of individuals to make some conclusions from. That's why University of Kentucky didn't do a specific cost benefit analysis this year, or at the end of this first grant year, because that data is not there to be reliable enough to make decisions on. It's better once we have a number of individuals that we can track over a given period of time. At the end of grant year 1, we only had 4 folks who qualified for a 6-month reassessment. That means everybody else had been with the program for less than 6 months. And I don't think we are in a position to make a determination about how much did we save for this person from month to month when we don't know what's going to happen the next month with that individual. They're going to need all new housing that we'll need to pay for. They're going to need to be returned to the hospital for a 30 or a 60 or a 90-day period. There's so many variables that in order to make a useful analysis, we wanted to have sufficient time and clients to do that.
I understand that, but I appreciate your explanation, but there should be an understanding of where you stand right now in terms of how this person is going through the program, in terms of what's going on. I know you asked, or at least there's a $500,000 that's in the budget in addition to the $1 million. trying to figure out where, how that money's going to be used and so forth. But we can talk about that in a second. But I think Representative Sheldon has a question.
I think most have been answered, but let me just mention, first of all, I think bringing those resources together the way you talk about and giving people an opportunity to make it once they leave, I think that's grand, and that's the way it should be handled, and I applaud you for doing that. Kind of brings into my mind, though, a couple of different times there were third-party payer. I think you mentioned, and maybe somebody else, that most people had some type of third-party payer, if not all or nearly all. Would that be a correct statement? As far as for medical benefits and that type of thing, but that's not necessarily true on housing or transportation. I wouldn't think as much, but for the most part, there are other resources that you all have used to provide those services for the very reasons you gave me, right?
For the most part.
Yeah, for the most part. I realize there are exceptions. So I guess now I'm thinking, all right, and this, I know this is way too simple, and this is quick answer, I'm sure. So if we spent $400,000, I'm just trying to think in my head. If we spent $400,000, would you say half of that went to staff salary, the other half went to transportation and housing? I don't know. I don't know how, because I know it's going to be broken up into little bitty pieces. I'm trying to look at the biggest pieces.
Salaries.
Yeah. Well, I guess that would be in most businesses it is.
I think if you look at the grant application, that sorry. No, it's on.
Just get closer to
I think if you look at the grant application, that the bulk of the funding, it goes to salaries.
You're right.
To paying staffing.
Right.
And then a very small portion, and just from, I tried to assess exactly how much we've spent.
Right.
I think we've spent very little of out of pocket money towards the actual housing costs. So I think that's a
Great.
Small amount.
Great.
There's been some.
I'm just
obviously.
curious, yeah.
There's been some. Obviously, we've had to, and I know there's been some in Hardin County as well. But I would say for the most part, it's only a few individuals who have got some housing money. Most of it is their housing. It's a few of them that are in family care homes. Like I said, the one individual, but that money was coming from other sources.
Right.
And most of these folks have SSI benefits, so when they go into these placements, they take their SSI as as a trade, and so most of them are going into that. But like I said, like 14 of the present folks right now are with family or they're paying for their own.
Good.
So I do not believe that we're expending a significant portion on housing currently.
Good deal. I guess where I was trying to, obviously underestimated. So are you saying the larger percentage of that 400 really is salary?
Salaries.
And the rest, your services are primarily, not all, offered through resources you've been able to gather together to help them continue on with this program, so to speak, after they leave.
Yeah, their sources, the resources
gotcha.
that they are getting are through their Medicaid. They're billable to Medicaid mostly.
Okay,
Their
thank you very
treatment.
much.
Their treatment.
I just needed, thank you so much, and
You're
appreciate the presentation.
Thank you.
That is accurate. It is mostly salaries is the highest portion of the expense because we're not able to, with the federal funds, pay for an individual's housing on any kind of continued basis. We might be able to pay for with these grant funds. They have found the practitioners have found some other funds, the Olmstead funds, some of the ACT funds are a little more flexible, so folks have been able to use that. That's always what you're chasing when you have grants is flexibility of funds that have sufficient ability to be used for those different things as they come up on a per person basis. But we look at every opportunity. Like I said, the grant requires that all of the expenses, they be the payer of last resort. So if they can find Olmstead, or they can use SSI, or they can use an ACT program to pay for a housing expense, or put them in an existing agency program, that has to be done first.
And it sounds like you all have been successful at that. So thank you very, very much.
It's a big challenge.
Representative Bowen has a question, and I have a question, and we need to go ahead and wrap it up.
Right, I'll be quick. Judge, you mentioned you've had 31 in Jefferson County, and then 12 have gone to
Total.
Correct.
Total between both counties.
Okay. And currently you have 17. You mentioned that you had one that had completed the program. Is that correct?
Yes, he finished.
Okay.
Well, two. Well, we've had one since the grant. We've had one prior.
Okay.
And then we had one was pretty much terminated because we couldn't find him.
Okay. I realize, like, with just starting in December of 2020, that we're just now in the 14th month of the program.
Mm-hmm.
How is that individual doing? I don't know how long it's been since he completed the program, but how is that individual doing? And is the program, is it set up to, I know ultimately we would love to put people on the right course for the rest of their lives, but is the ultimate goal that, or is it to save resources in the meantime, or both?
So they're still getting services.
Right.
The services they were getting.
Right.
And maintaining.
Right.
So that's the goal. We wanted to set them up to be successful and maintain, and they've been able to do that.
Right. And stay out of the court system.
And
jails and
I thought you would ask the question about kind of what do I see as the success rate.
Mm-hmm.
And when I spoke with Hardin County, we kind of have the same belief that about 1/3 of the individuals are hugely successful. They're great. They're not hospitalized. They're not having more contacts. They're doing really well in their environment. The placement's stable. They're taking their medication. We have about 1/3 who are better, and we've reduced, hospitalization. They're not in jail. They're doing, we're definitely making much progress, but they may not be perfect. We may have a trip back to the hospital or something, but we've made marked progress. And then we have about 1/3 who have either, like I said, we've had 2 deaths to drug overdoses. They had an individual who is in jail. We've had two individuals in jail. Mm-hmm. So we've had a couple people come into the program who, one woman, she's not been rehospitalized and she's not gone to jail. She will not engage with us. She won't come out of her house. We're giving her certain services and stuff kind of through her family and making sure she's getting her medication sent to her house and things like that. We don't believe she's taking it, mm-hmm. but we know where she is. We're monitoring the situation, but she's not engaging with us. So we kind of, those folks who just truly we cannot engage, they're kind of on that end of, they're not worse, but
right.
We don't really feel like that's a huge success for us.
Right.
But
okay. Thank you. That's good information, and thank you all for the information today.
I got one last question. We'll go ahead and wrap up. I wanted to ask Ms. Dickinson more of a cultural question. In looking at some documents, some court documents a couple of years ago, there was, I guess, an approach to implementing Tim's Law was rather disconcerting to me, and I want to see if I guess I want to get your opinion on it. And let me extract just a couple of comments. Basically, in one of it's a whistleblower program. You might be familiar with it. I don't know. But there's a whistleblower case that came out, and one of the statements in one of the counts was like the first attack was to make sure all employees and contractors of state-run facilities be educated and aware that Tim's Law was not part of the governor's agenda and should be avoided at all costs. The second wave of attack was not to fund this type of a treatment, to communicate to all state-run or funded facilities that there was no money in the budget to carry out Tim's Law's treatment programs. And the last comment basically is require state employees and state contractors and employees at facilities that are to monitor the court's dockets and keep individuals and defendants apprised of the Tim's Law cases that might be on the docket. The docket referred to is in Jefferson County, and I want to get your comments and thoughts. And and I'm sorry, but it seems to me that there might be some concern that maybe we haven't reached up to the 50 that's projected, and you only have 30 start. So is that, what's the culture there? I mean, is it very open? We want to help and get this thing implemented in full and be open and transparent to make sure this happens.
If I could speak to that, Tanya, can we go? Yes, I can't speak to those exact comments, but what I can say is when Tim's Law was passed in 2017, there were no funds provided for it. And so our department, we always want to serve individuals in the least restrictive environment. So we on our own solicited grant funds so that we could implement. And what I suspect is those were comments, and I don't know the exact comments, but what I would suspect is that those were probably pre the grant funds that were available. And so at that point in time, we would have wanted to make sure that anything that was filed appropriately. And again, there was no funding provided to provide the services. And that is why we solicited the grant, was to obtain funds so that we could implement the law in a pilot project. And again, we're excited about the opportunity possibly to expand this to the other regions, but our intent would be over the 4-year period to prove that there is some savings involved so that we can take the program on a larger scale.
Okay, well, thank you. I appreciate that explanation and so forth. And once again, this is a budget review. We deal with a budget and costs and so forth, and we need to have a good, strong understanding of the cost benefits in order to go forward. And there seems to be a significant amount of savings. But more important, we are actually providing a system of care to those who are least among us to make sure they have more of a functioning life. So with that, I don't see any other questions on my list. I want to thank the judge and the ladies from the department to come and give us a testimony. And with that, we stand adjourned. Thank you.
Thank you so much.